Imagine a patient presents with progressive hearing loss and a hint of facial numbness. You look at the scan, and there it is, a mass in the cerebellopontine angle. It looks like a classic vestibular schwannoma, right? But what if the internal auditory canal is normal? What if it's a diagnostic ghost hiding a more aggressive pathology? Today, we aren't just looking at scans. We're solving the case of the silent angle. The clues is vestibular schwannoma versus meningioma. Story is walk through the most common suspect. Key teaching points: focus on the ice cream cone sign versus the dural tail. Show the widening of the internal auditory canal, IAC, as the smoking gun for schwannoma. Clinical pearl. Mention that schwannomas usually center on the internal auditory canal, while meningiomas are often eccentric. The plot twist. The epidermoid, wolf in sheep's clothing. Just when you think you have it narrowed down, you see a lesion that looks like cerebrospinal fluid on T1 and T2. Is it an arachnoid cyst? Not so fast. Key teaching points. Introduce diffusion-weighted imaging, DWI. Show how the restricted diffusion reveals the epidermoid cyst, but if it is free diffusion, it will be arachnoid cyst. Cerebellopontine angle masses can be summarized in the following smart art. The most common lesion, which is vestibulocochlear schwannoma, followed by meningioma, epidermoid, and arachnoid cyst. In addition to cholesterol granuloma, differentiation of these lesions are mentioned in smart art. In radiology, the story is in the details. Don't let the CP angle remain a mystery. If this case helped you, subscribe for more neuroradiology deep dives.